Hello, my name is Kendra Clark. I am coming from Scottsdale, Arizona. I have a laser aesthetic practice both in Tempe, Arizona and Scottsdale, Arizona. I'm happy to present on behalf of IS Clinical University today with a topic of Neurotoxins 101. Interestingly enough, the first strains of botulinum toxins were discovered by a scientist trying to understand food poisoning. In 1877, a German scientist, namely Dr. Kerner, determined that there was a toxin in spoiled sausages that were making people ill and first explained the disease what we now know as botulism. Doctors Alan Scott and Edward Shantz worked on a standardized botulinum toxin preparations in the 1960s, developing therapeutic applications for botulinum toxins. On April 15, 2002, the FDA announced the approval of botulinum toxin to temporarily improve and remove moderate to severe wrinkles, including forehead lines, crow's feet, and especially glabellar lines, those beautiful 11s between the eyebrows. Botulinum toxin was also approved for the treatment of hyperhidrosis, excessive sweating of the armpits, when cases that antiperspirants failed to treat. What is botulinum toxin A? I will interchange the terms botulinum toxin A with the term neurotoxin. Please keep in mind they're one and the same. Botulinum toxin type A is a common ingredient in the injectable neurotoxins better known under the brand names such as Botox Cosmetic, Dysport, and Xeomin. What is the difference between Botox, Dysport, and Xeomin? Well, the main distinction lies in their formulations, which influences the dosages used, how much of the product may spread, the amount of accompanying protein or lack thereof, and how quickly a patient might see the results. For example, Botox Cosmetic is formulated with an accompanying protein called clostridial protein, where Dysport contains a smaller version of the similar protein, whereas Xeomin does not contain the accompanying protein at all. However, all three products are FDA approved and have been used safely and effectively for years, and all are designed to address the same types of wrinkles and other cosmetic concerns. Since cosmetic botulinum toxins are purified in the lab and injected in very small amounts, these proteins do not cause botulism. We will briefly discuss microbiology. Botulinum toxin is produced by the Clostridium botulinum, which is a gram-positive anaerobic spore-forming bacillus. Now, botulinum toxin is broken into 7 neurotoxins labeled as types A, B, C, D, E, F, and G, which are antigenically and serologically very distinct, but structurally very similar. Type A is the most potent toxin, followed by types B and F. Human botulism is caused mainly by types A, B, E, and rarely F. How do neurotoxins actually work, and what is their mechanism of action? Well, botulinum toxins block the neuromuscular transmission by binding to receptor sites on motor nerve terminals, entering the motor nerve terminals and inhibiting the release of acetylcholine, which essentially activates muscles. So in essence, when injected into the muscle at therapeutic dosages, botulinum toxin produces a partial chemical denervation of the muscle, resulting in relaxation of the muscle. So the Cliff Note version is treatment works by blocking motor nerve impulses to the muscles, causing them to relax. The toxin requires about 2 to 4 days to take effect, peaking at about 10 days. The effects of botulinum toxin last nearly 12 to 16 weeks. Are these neurotoxins just for wrinkles? No. We have aesthetic indication and non-aesthetic indications for neurotoxins. Aesthetic indications for neurotoxins include horizontal forehead lines, glabellar lines, otherwise known as frown lines or the 11s between the eyebrows, wrinkles around the eyes such as crow's feet, corners of the mouth, the cobblestone appearance of the chin, wrinkling of the nose, platysmal banding in the neck, and please keep in mind that neurotoxins are most effective in dynamic muscles. Those are muscles that cause wrinkles that are formed as a result of facial movements like frowning, squinting, smiling, and other expressions we tend to make every day. Additional therapeutic uses for botulinum toxins, these are non-aesthetic indications. Initially used to treat blepharospasms, Botulinum toxin now has over 100 potential medical applications, from spasticity in cerebral palsy and other neurological disorders, to smooth muscle hyperactive disorders, to nasal allergies, to chronic migraines, and so on. Contraindications: do not inject if patients are afflicted with pre-existing motor neuron diseases such as myasthenia gravis, Eaton-Lambert syndrome, or chronic neuropathies. Also, history of reaction to neurotoxin or albumin, pregnant or lactating females, injection at the injection sites. Be mindful that various medications decrease neuromuscular transmission. Generally should be avoided in patients treated with botulinum toxin. Some of the medications include, but are not limited to, aminoglycosides, calcium channel blockers, penicillamine, or blood thinning agents. It is important to find an injector with proper training, credentials, experience, an aesthetic eye, and skillful technique. A thorough knowledge of facial anatomy and functionality of the facial muscles both at rest and during contraction. Even with a solid clinical knowledge, much experience, and an astute eye, each patient comes with his or her own blueprint. It is imperative that each time we, as injectors, stop and pause and assess each patient's blueprint before we inject. I remember back in kindergarten during a fire drill learning stop, pause, and roll. Well, when I teach new injectors, I like to remember to share with them the importance of stop, pause, and assess. Every patient is different with a different blueprint. The importance of a pre-procedure consultation and informed consent cannot be stressed enough. History taking should include history of medications used, history of allergies, and any past adverse events. Examination of the area being injected. No active inflammatory response should be present. A second consultation I often will try to provide, because the first initial consultation is their primary reason for being there. Oftentimes they go home, they look online, they talk to friends, and they come back with a different expectation. So I like to always provide a second consultation. Also, pre-procedure photography is mandatory. Informed consent, always discussing risk versus benefits, and of course, mutual expectations. Botulinum toxin comes in a powder. When reconstituting neurotoxins, use a non-preserved 0.9% saline, with a dilution of saline depending really on the neurotoxin of choice. Insert the needle about a 45-degree angle, slowly inject the 0.9% saline into the vial. Discard the vial if the vacuum does not pull the diluent into the vial. Also, gently rotate the vial and record the date and time of reconstitution on the space on the label. Syringes with a 30 to 32 gauge needle are recommended, and be sure to expel any air bubbles, if any, and confirm the patency of the needle. Topical anesthetics are generally reserved for the very sensitive. Ice could be used topically as a numbing agent if needed, and doses are tailored according to the individual, the patient's age, the personal history of the patient, the density of the muscle, and of course, the type of neurotoxin used. Now we're going to talk about basic general principles of the injection technique. Of course, the bevel of the needle should always be facing upwards as the needle penetrates the skin, almost parallel to the skin. When the needle is advanced for about 2 millimeters before injecting intradermally. The thumb is then taken off the syringe plunger for about a second or two before withdrawing the needle. These measures help prevent backflow of neurotoxin and limit wasting. In this lecture, as I mentioned, I will cover general principles of neurotoxin injection techniques. The advanced techniques, such as specific dosages or units or additional caveats relative to neurotoxin injections, can certainly be covered in a subsequent lecture. Let's begin with the glabellar complex. These are the vertical frown lines, also known as the 11s between the eyebrows. The glabellar lines are created by the actions of 3 muscles: the corrugator muscles, the procerus muscles, and the depressor muscles. Before initiating treatment, always assess facial expressions at rest and during contractions, and evaluate the range of motion along with palpating the muscles during rest and contraction. Always assess your patient's brow position. Also, be mindful when injecting the corrugator and procerus muscles. Avoid injecting too low over the orbit. With lateral brow injections, stay well above the superior orbital rim. Fortunately and very rarely do adverse events occur, but most common complication in the treatment of the glabellar complex is ptosis of the upper eyelid. Injections placed too low in the mid-pupillary region can cause diffusion of the toxin through the orbital septum, where it can affect the upper eyelid levator muscle. So symptoms can persist about 4 to 6 weeks or sometimes longer, and treatment is with an alpha adrenergic agonist, known as aproclonidine at 0.5%, with a dosage of 1 to 2 drops 3 times a day until the ptosis resolves. Next, let's discuss horizontal forehead lines and the treatment of the frontalis muscle. The treatment goal here is to achieve a balance between brow elevation and forehead softening. Before initiating treatment, evaluate your patient's anatomy and functional movement, muscle mass, symmetry, lateral versus medial movement, and compensation for brow ptosis, and a narrow or wide brow. Novice injectors should stay about at least 2 centimeters above the brow and ensure that injection sites are lateral enough to avoid Spock-like eyebrow appearance. The most significant complication of treatment of the frontalis is brow ptosis. The results from over-aggressive treatment with injections being placed too low on the forehead or from poor patient selection. I have observed in my patients around age 50 to 55 years or older who often use their frontalis muscle to keep their eyes open. In these patients, relaxation of the frontalis may result in ptosis of the brows and or feel heaviness in the eyelids. I personally stay high in the frontalis when treating my patients. When I ask them to lift their brows and contract their frontalis, I then intentionally inject above the lowest fold of their forehead. If the patient has low eyebrows, treatment of the forehead line should be avoided or limited approximately 4 centimeters above the brow. When treating the forehead for the first time, I may reserve treating the forehead area for 2 weeks after injecting the glabella area. Then I may advise initially starting with a lower dose in the forehead to reduce the chance of depressing the brow excessively. Let's now discuss crow's feet, which is a contraction of the orbicularis oculi muscle. Before initiating treatment, please determine the source of the wrinkles, whether from the orbicularis oculi muscle versus the zygomaticulus major muscle. Always assess the patient's functional movement as well as the skin laxity along the lower lid margin. With age, the muscles weaken and collagen, which is the protein that gives structure to our skin cells, decreases, causing skin laxity and looseness. Beneath the skin and muscle, the main culprit for under eye puffiness is fat. The law of gravity is no respecter of fat. Fat displaces or migrates to surrounding tissues or both. In either case, neurotoxin injections can exacerbate the under eye issues if the inferior fibers of the orbicularis oculi muscles are relaxed. Keep injections superficial. Use intradermal or subdermal blebs with a needle oriented away from the orbit. I place a finger on the lateral aspect of the orbital rim and inject very small amounts, treating the lower third of the canthal area with caution. Avoid the area below the zygomatic arch and the zygomaticulus major muscles. Injection in this area has the potential to cause lip or cheek ptosis. Avoid veins as this area is highly vascularized and or treating patients who have a history of dry eyes. Next are the bunny lines. Have your patient contract the transverse portion of the nasalis before initiating the treatment. Patients should be asked to laugh, sniff, and squint. Functional movement should always be assessed. Injections are given into the nasalis muscle. Keep injections superficial and to avoid bruising. Do not massage vigorously this area or in a downward direction. This could result in upper lid ptosis. Next is the dimpled chin. Correction of the mentalis muscle can treat the cobblestone appearance of the skin and possibly the deepening of the mental labial crease. Before initiating treatment, always assess functional movement and have the patient animate the movement which provide wrinkles. Treatment in this area is either 1 central or 2 lateral injections, approximately 1/2 to 1 centimeter above the lower chin edge. Injection should be kept at least 1 centimeter inferior to the lower lip. Caution when injecting the toxin too high, which can affect the orbicularis oris muscle and cause lower lip compromise. Next are the platysmal bands. As we age, we develop these lovely bands due to the separation of the midline platysmal muscle and loss of supplemental fat, creating vertical bands in the neck. Can give the appearance of what is appropriately called this time of year a turkey neck. Treated with a series of superficial intradermal injections directly into the contracted muscular band of the platysma. The number of injection points depends on the length of each band. Grasping the band with a non-injecting hand might help when injecting very superficially into the contracted muscle. Caution to avoid the strap muscles as to not create dysphagia, dysphonia, and/or neck weakness. Platysmal band injections do not substitute for surgical procedures and will not correct skin laxity and/or fat deposits. I call the next area droopy dog. The contraction of the depressor anguli oris or DAO muscles can give the appearance an impression of sadness as the oral commissures droop downwards, increasing the appearance of marionette lines. The aim of this treatment is to lift the corners of the mouth while the patient is at rest, typically treating 1 injection point into the posterior aspect of each DAO. Injection should be 1 centimeter at least lateral to the mouth corner to avoid adverse outcomes. A second injection site may be added laterally to target the platysma. I might suggest starting with a low dose and titrating up from there. Following the injections, various precautions can be discussed. Many injectors instruct patients to contract the injected area for approximately 90 minutes to 2 hours, which can aid in the uptake of the toxin. Some providers suggest avoid bending or lying down for 4 to 6 hours after treatment to avoid potential diffusion. Also suggested is avoiding strenuous exercise for 24 hours. Refrain from laser, intense pulse light therapy, radiofrequency, or other aesthetic procedures that may cause toxins to migrate to surrounding tissues due to increased blood circulation or direct pressure for 2 weeks after the injections. Adverse events are extremely rare, however, can occur at the injection site, including pain, erythema, ecchymosis, edema, and short-term hyperesthesia. Extremely rare, generalized reactions including nausea, malaise, flu-like symptoms, and cutaneous eruptions may result from diffusion of neurotoxin into the systemic circulation and is treated precisely based on symptoms, unfortunately very rare. Now let's conclude. Initially used to treat strabismus and blepharospasms, botulinum toxin is now an accepted treatment in a wide spectrum of disorders and has over 100 potential medical applications. The anti-aging benefit of neurotoxins is extremely gratifying, and if injected in small amounts into the face and neck muscles, can improve the appearance of facial lines and platysmal bands for several months. Adverse reactions, fortunately, if any, are usually very mild and transient. Thank you very much for joining us today with our lecture, Neurotoxins 101.